To the pros and cons of arthroscopic cuff repair, I have no declaration of interest. Is this procedure really a great leap forward for us, or indeed a triumph of technology over reason? Early on, as with any new procedure, it starts with a band of loyal followers, and it has grown and continues to grow at an exponential rate. It's performed now by most new graduates and is the preferred method of arthroscopic cuff repair in a lot, if not most, tertiary institutions. There's a lot of pressure from industry to move in this direction from GPs and other referrers and from the public. And of course, there are people out there who do a lot of this sort of work on the speaking circuit to try and make everyone else feel inept if they don't do it this way. This procedure, perhaps even 10 years of transition, has seen its move from an early procedure with limited instrumentation, with poor anchors, weak sutures, better range of anchors, stronger sutures. There are knotless techniques and better video equipment available. And I think the more widespread acceptance of upright positioning of patients has allowed and facilitated the growth of this area, as it is arguably a little easier to perform this type of surgery in the upright sort of seated position. So just taking a step back briefly and looking at rotator cuff biology, in a way it's an exercise in restoring unhealthy anatomy to a normal position. It's worth remembering that rupture of healthy cuff rarely happens, and that torn cuff is dead cuff. And there are multiple changes, including apoptosis, chondroid metaplasia. Tendon interface is a four-layered structure with the tendon transitioning through fibrocartilage to the bone, whereas the repair site at best is disorganised scar tissue. The Sharpie's fibres, which confer it some strength, don't appear until after 12 weeks, as David Sonnabend has shown in his baboon studies a few years ago quite nicely. As a result of this, there's no place for early loading following arthroscopic cuff repair or any rotator cuff repair. And there is some work actually showing a trend has moved towards double row repair, where a couple of rows of suture anchors are placed with sutures through the cuff material more medially and then at the lateral margin, to improve the area of contact of the rotator cuff to the bone, as we can see in picture C, where there is more of the cuff tissue actually covering the greater tuberosity and theoretically more ability to heal. And then from there, we move to what is called the transosseous equivalent double row repair, where the rows of anchors are linked with the suture spanning the cuff in order to place more pressure over the cuff itself at its area of attachment to the bone. And this, in profile and in structure, mimics traditional transosseous, where measurements are taken beneath the cuff show that there is more pressure and better maintenance of contact pressure with this type of technique. But it also introduces new concepts of whether we're strangling the cuff and maybe impairing its vascularity. Mason-Allen suture. We know that failure point is at the point of contact of the sutures and the cuff. The actual suture anchors and the strength of the sutures are very good now. Traditionally, the modified Mason-Allen suture is a very good way of attaching rotator cuff, with the tension in the vertical limb through to the cuff material is spread through its contact with the horizontal mattress component of this suture. And this can be replicated arthroscopically or in any other fashion using these suture anchor techniques, as we can see with the medial row there of double loaded anchors with a Mason-Allen type variation with a horizontal mattress suture tucked beneath the vertical row there of the slightly broader suture material. Video here just showing a typical chronic supraspinatus tear, which has been partly debrided and being evaluated for repair. And here on the top there, the thinner strands of the horizontal mattress suture with the two broader tape materials being brought through at a more medial location. Once those are brought down over the top of the cuff material, as in the diagram, and tacked into the lateral row, it completes this type of double row repair with the Mason-Allen variation at the medial point. So this is okay, but let's try and look critically at what are the perceived advantages and disadvantages of arthroscopic repair, and see what's published along these lines. So advantages that are touted are a better ability to assess and treat additional pathology, certainly when compared to when no arthroscopy at all is performed. Earlier restoration of range of motion, less pain and perioperative morbidity, better external scarring and lower infection and complication rates. On the downside, perhaps it doesn't work as well. There's certainly a steep learning curve. It's more expensive, more time consuming, and perhaps it's unnecessary given the success of open techniques. And any time we look at this debate, I think it's important to look critically at its comparison to open rotator cuff repair, and by that I'm mainly referring to mini-open, where an arthroscopy and evaluation is performed, and the repair is actually done through a small open wound. So moving on to look at this. The literature I thought I'd break down into three categories, looking at its efficacy, comparing it to mini-open rotator cuff repair. Firstly, the inherent strength of the attachment to the bone. Secondly, the actual healing rates of the tendon in vivo. And thirdly, the clinical results. Arthroscopic repair is by a long way performed by a suture anchor technique, so it's worth looking then at suture anchor repair initially versus transosseous sutures. And there are some reports by some reasonably high-profile names there of laboratory studies favouring transosseous suture repair, but it seems to be that the majority of reports do have a preference for suture anchor repair, with many mechanical parameters being shown to be better, and a lot of studies looking at single row versus double row repair, mainly if they are compared to transosseous, seem to come out showing a mechanically favourable construct. The proviso then is that can this suture anchor based construct be achieved arthroscopically rather, when they're put in open in the lab in these testings. And there is one study that looks at the arthroscopically inserted suture anchor repair versus transosseous sutures and versus a now defunct cuff tacks, showing suture anchor repair to be strongest. So in conclusion to this aspect, the construct achievable with arthroscopic techniques is at least as strong as those performed through open approaches. In actual cases, in many times it's just the same repair as is performed by a mini-open approach. So then what of the healing rates? Do the rates of cuff healing differ between arthroscopic and open repair? And does it really matter? Because a lot of the clinical improvement is conferred by the decompression and debridement and bursectomy. It's well accepted now, though, that although clinical results do remain good after a failed cuff repair, better results are seen when the repair is actually intact. And in many studies, they're quoted even going back 20 years, regardless of what type of repair is performed, showing that it is actually worthwhile trying to get it right. And all of those parameters listed below are shown to be improved when the cuff is intact at the end of the procedure years down the line, rather than when it has gone on to fail. So healing rates after rotator cuff repair, mainly due to the biology of what's going on, vary very highly regardless of technique, and failure rates of 5 to more than 70% are reported. And the predictors of failure that come out in the literature are quite consistent, and three of the important ones are age of the patient, the larger tear size, and fatty degeneration of the muscle involved, do push the rates of failure quite high. Descriptions of open repairs, and some quoted there showing 20, 24 and 20% failed repair, are pretty representative. And a recent evaluation of mini-open repair shows a 17% failure rate. So looking at comparative trials between arthroscopic and open, there are a lot of trials, although relatively poorly constructed, unfortunately, on the whole, that show no difference in rates of cuff healing when repair is performed arthroscopically as opposed to open. And these are with usually ultrasound or MRI follow-up. Some studies have shown poorer healing rates with bigger tears, such as Plato's work, where larger tears were shown to have a higher failure rate rather than small ones. A systematic review of studies where appropriate follow-up and imaging outcome were performed did show that the type of surgical approach, whether that's all arthroscopic, mini-open or open, didn't affect the re-tear rate of rotator cuff repair. This happened to be looking at double row repairs. The newer repairs now, there are a lot of studies going on showing high healing rates, and often in excess of 80% and even 90%, averaging across tear sizes. And many of these are in the context, however, of trials between single and double row repairs, and it's been quite a while since anyone has published raw comparisons between arthroscopic and open. Incidentally, on that point, a recent meta-analysis seems to show double row repair coming out a little bit better at the moment in terms of actual healing rates. So in conclusion to this, rotator cuff healing rates with arthroscopic repair are equivalent to those with open techniques. Now looking at clinical results, early papers were relatively poor, and were showing worse results with arthroscopic repair where the tears were large or where there was a lamination of the tear. Graham McDougall from Sydney, in support of this, also showed and presented this a little while ago at the shoulder meeting that the presence of lamination seemed to have no effect on the outcome when the repair was performed by mini-open repair. So indications were that arthroscopic repair should be reserved for smaller tears only. However, again, a large number of relatively poorly constructed clinical comparative studies do show no difference in outcome between arthroscopic and open cuff repair. A systematic review recently published shows this as well, and again with no very well constructed trials. There was nothing in Cochrane, and meta-analysis of 5 trials with appropriate outcome measures, but no randomised trials in that, importantly, didn't show any clinical outcome differences between the 2 methods of repair. In revision, there were no comparative studies noted, but individual reports of repair, of revision repair, open and arthroscopically, seem to show the same types of results, and that is that most of them fell apart anyway in 2/3 of people roughly. So in conclusion, there are no recent studies showing any difference in outcome between arthroscopic and open rotator cuff repair, but as I've mentioned, most of them are relatively poorly structured. And in favour, however, of arthroscopic repair is that techniques are still improving, and literature tends to lag behind this by a few years. So altogether, comparable strength of repair, healing rates of the actual cuff appear to be the same, and equivalent clinical outcome. So we've perhaps established that it works well enough, and so now to look in less detail at some of the other disadvantages. It's more expensive. Well, in 2006, there were 5,000 day case rotator cuff repairs analysed by this group in New York, of which in a ratio of 3:1, they were performed via all arthroscopic means compared to mini-open. And the prices shown there showed that the arthroscopic repair were approximately $1,100 more expensive, or approximately 15%. In the UK, there's a bit of concern about this costings as well lately, and a particular comparative review there showed the arthroscopic repair to be £675 more expensive per case, and no difference in clinical outcome scores, inpatient stay, physio requirements, etc. They concluded that open repair has greater cost utility. This has been shown by some other people. Had a quick look at an example of a rotator cuff repair in a Melbourne private hospital, a 1-night admission, excluding medical fees, and a repair based on suture anchors with 4 anchors. Arthroscopic repair and mini-open, if we go straight to the figures in red, didn't come out to be particularly different. The reimbursement to the hospital for mini-open repair is greater, and the cost of disposables is greater on the arthroscopic side. And this is not including instrumentation, however, and that's not insignificant. It's usually provided by industry, but there'll be an indirect cost there. And looking down the bottom, altogether there's no difference. In fact, if medical fees are included, again, there's no particular difference noted there. The cost of arthroscopic repair is higher to hospitals. They do have to foot the bill of disposables. They may have to provide instruments if that's not done by industry, and there's lower reimbursement from the funds for that type of repair. More time consuming. The same New York study looked at operative time. Subacromial decompression and mini-open repair seem to have an average of 103 minutes of total operating time versus all arthroscopic. This is in that same 5,000 patients. Time of 113 minutes, which it was quite significant. However, they looked at high volume centres within all of that and found that the average arthroscopic time of repair was 77 minutes. On balance with proficiency, and the length of time for a typical repair is similar to open, and smaller repairs can be quicker. With respect to the learning curve for this procedure, there's no doubt that it's quite steep, and the figure is difficult to quote, but it may be hundreds before one's able to actually feel comfortable with this and bring the operating time down. I was told by some of the more senior, older guys around town, like John, that in the early days of knee arthroscopy, when you had to look down at the crouch down, look into the eyepiece, it would take hundreds before people felt comfortable with it, and it's maybe not such a dissimilar situation. There are multitude of technical difficulties with arthroscopic repair, with particularly suture management, unloading anchors and placing them poorly, poor tissue management, and an oversimplified repair in an effort simply to get a result done. will inevitably lead to poor early results at this phase in one's practice. We have to ask if that's justified, and is the early morbidity in any new procedure justified? And this is a key question. This is an X-ray day 1 post-arthroscopic cuff repair with slightly suboptimal placement of the anchors. Looking at complication rates, overall there was a little bit in the literature but not a great deal. It seemed to indicate that overall complications were around the 10% between arthroscopic and open. There were some conflicting reports, but there was nothing really to indicate that one was better than the other. When we look at overall complication rates, stiffness being one of them is still an issue with arthroscopic repair. It needs to be borne in mind. There's an incidence of capsulitis, an incidence of just capsular tightness that's difficult to get over in arthroscopic repair, and this actually accounts for the majority of reported complications. Infection rates itself, mini open repair reported at 1.9%, shoulder arthroscopies at 0.16%. Now, arthroscopic cuff repair wasn't specifically reported, but teasing that incidence out of some of the literature at figures of 1.3% and 0.38, and overall arthroscopic complication rate for infection appears to be less than 1%. Other complications we know about, and prolonged arthroscopy can lead to fluid issues and brachial plexus neuropraxia, and there are a few arthroscopic specific complications to bear in mind with this type of work. So in conclusion, there was a trend towards more complications in the open group, and this was shown also by a systematic review, and a lower infection rate. Earlier range of motion, there is no evidence for any change in final range of motion between arthroscopic and open repair. There is something to say that perhaps there's a slightly earlier regain of range of motion and basic functioning, but in having said that, there are contradictory reports to that effect as well. And in any case, I don't believe there's any clinical advantage, because in any way in my practice there's no isotonic exercise, manual work or any other loading of the arm allowed until after 3 months after repair, if David Sonnabend's work is to be believed. And better healing rates, in fact, have been shown to occur in the subgroup of patients who have excessive stiffness in some reports. And to skip through this a little bit, there's nothing in the literature showing anything useful with respect to immediate postoperative pain, unfortunately. There are some showing longer inpatient stay and some showing lower pain scores at 3 and 6 months, but there's really very little to go on. And most of this is really our feeling anecdotally from high volume practice of this type of work that there is probably a little less pain going on. Perioperative morbidity, deltoid trauma, certainly better than when the deltoid was detached from the acromion, but compared to mini open, I don't think there's anything in that really. Interleukin-6 even was used as a marker of tissue insult in one study, shown to be lower in arthroscopic repair, but mini open repair is a low morbidity procedure anyway, so there's very little in that. Assessment of additional pathology, well, if arthroscopy is not performed, there's undoubtedly a problem. So I'm making my comments based on comparison to arthroscopic evaluation of the shoulder, decompression, and moving on to repair. People prefer it if they've had an open on one side and an arthroscopic on the other, and the scars do behave better than if you add up all of the scars and compare it to a single open scar, as some people like to quote. There's something in meeting patients' expectations, and I think people like the idea of having arthroscopic procedures. So what are the proven advantages in the end? Less infection, improved external scarring, maybe less pain, better management of other pathology, certainly when no arthroscopy is performed, meeting patient expectations. Subjectively, I certainly feel that there is better assessment of the tear, of lamination and mobility, etc. arthroscopically, improved access when multiple tears are involved, and more controlled releases. It's easier to pass sutures when tendon is retracted in a tight space back to the glenoid, and when everything is not red and down a deep hole. And the surgery is more comfortable, there's less rotator cuff tearing in my assistance, and overall there's less pain. Disadvantages, it's certainly more expensive, it's more time consuming, technically demanding, and the results are no better just yet. So in conclusion, in experienced hands, arthroscopic repair is another way to get the same result, essentially, not a faster result, in the same way as arthroscopic ACL reconstruction is not done to get people back to sport more quickly. There are some advantages there for those who do it a lot, and it's a natural evolution of a technique for which evidence exists for its continued use. With infrequent practice, the cost, duration of surgery and high likelihood of suboptimal repair or complication don't justify its use. And so ultimately, flattening a learning curve, I feel, is a big issue with arthroscopic repair, given that if done properly, it can work. So further training is usually advisable in a transition of doing the procedure through open. So it's a procedure not going away, and we need to work out how to do it well. Thank you very much.